here. Hi, how are you?
Hi, Dustin. I'm doing great. Thanks for having me. I really appreciate it.
Oh my gosh. I should say I reached out and I was like doing some research because I wanted to do something on borderline personality disorder because it's something I've been hearing so much recently. And it's like this buzzword I think I've been hearing. And I think I've heard a lot of incorrect uses of it. And so I was looking up people and I found your page and I was like, oh my God, I have to speak with her. She has to come on. So I wanted to ask you just a little bit about you and who you are and like a little bit about your background and like what got you into counseling, like whatever you kind of like feel comfortable sharing.
Yeah, absolutely. I'm a licensed professional counselor in PA, and I'm also a certified advanced drug and alcohol counselor. So a CAADC, if you ever see that abbreviation in the state of PA. And I'm also certified in DBT, which is the gold standard treatment for borderline personality disorder. So I'd be the guru type of therapist you'd be looking for that type of diagnosis. So how I got into therapy, that's a great question. So I feel like I've always tried to understand people and human behavior makes sense to me on some way, shape, and form. And I think that's also why I was drawn to DBT in the first place. It's very behavioral focused and it made a lot of sense. So a lot of the things for BPD, as I learned about them, I remember in grad school learning about the criteria. I had no idea what it was. And I learned about it and I was like, I'm so intrigued right off the get-go. I was like, I want to meet these type of people. I want to know what they're all about. And we'll get into how I function with them probably eventually. But going through grad school, I figured out that I really wanted to understand the human behavior and the brain. So I actually went to Temple University for undergrad. I got a degree in psychology and I also got a minor in cog neuro because I was so interested in how the brain works that
Okay.
that was something that I just went into. So I took a lot of classes on that. I actually worked in an fMRI lab for a little bit too. So that was really neat to see like peak activations of the brain. I was like, this is so fascinating. But then I realized I can't be a lab rat for the rest of my life. I'd go
Mhm.
nuts. It would not be a fit. So I pursued a master's. I went to Penn State Behrend up in Erie. The school was great. I hate the snow though. So 10 out of 10 don't recommend for the weather. It's absolutely terrible.
Period. Yeah.
So
This
that's a,
winter's been rough anyway, like really rough anyway. And so
it
I don't know
really,
what the deal with that is.
yeah, it really has been. But I gotta say, in comparison to the Erie weathers, this is nothing. This is nothing. When your car gets stuck in the driveway after you shoveled it out twice in 24 hours, nope, not a
Ew.
place to go. Not for me.
Mm-mm. Ew. I want to tap into like, okay, so much respect for the cognitive neuro like minor. I took two like neuroscience classes and I feel like it would be a pun to say they blew my mind, but like I'm like just like the complexities that go into like neuroscience and cognition as well is like really crazy. So like double props to you and gold star that you minored in that because that's really impressive actually.
Yeah, thank you. It was challenging to say the least, but I also enjoyed it. So I was grateful that I found some neuro classes that were more of a fit. I remember the intro to neuro was actually one of the hardest that I took,
Hmm.
just because of the amount of biology that went into it and some of the mechanisms. Like I'm thinking about like the potentials for like potentiation and things along those lines and those crazy graphs. That to me was the indicator that neuro is not for me.
Hmm.
Um, but I've always been interested still in how the brain functions. So even when I'm doing research to be like up to date and understand trends, it's not uncommon for me to try to understand those papers because I find them fascinating. So even if I don't fully grasp it, I'll do my best, but
Hmm.
it's still intriguing.
Yeah, I think my clinical supervisor says to me, she'll be like, I'm not going to say this perfectly and I don't know exactly how to say it, so I'm just going to say it poorly. And that's kind of like what it like, what I kind of do with some papers too is I'm like, I'm not going to understand this perfectly, but like I'm going to if I understand it poorly, I'm understanding something.
Yeah, I feel like that is a wonderful way of pulling it down of like, I'm going to understand this to the best of my ability. And from there, we're just going to roll with it.
Hmm. Yeah, I love that. I'm curious about, so you went to Penn State for your grad degree. After that, what was the first couple of years as a counselor like for you? Like, did you know that you wanted to work with like a certain population, or did you have like a goal in mind?
Right. I had to even think back to what I was interested in. So I know when I originally went into grad school, and oh my gosh, I can't believe this is where I started versus where I'm at now. I know that I wanted to understand like young adults, and I contemplated couples counseling because my parents got divorced, and um, they didn't get along for the majority of my lifetime either. So I felt like I wanted to understand couples and help them work through things because I kind of played that role, I felt like, for a majority of
Mhm.
my life. So it made sense. But I went to grad school and we had a general course that was all about understanding like interviewing and counseling and basic principles. So we talked a little bit about marriage and family. And I realized I'm like, I don't know that this is a fit for me. Honestly, now I'm contemplating working with couples after having some different types of expertise, and I would like to branch myself out. Um, I stemmed away from it after learning more about individual diagnoses. Um, and then honestly, I think my internship was kind of what drew me into what I do now and continue to do. So I work with young adults and I really have since the beginning. I don't do kids, not my thing. It's just not
Mhm.
how I function. I don't know if that'll ever change. But I also said I'd never work in drug and alcohol, and I worked in it for 2.5 years. Um, I worked at a residential site for SMI. So that stands for like severe mental illness, if you've never heard of that, or serious mental illness. And it was a small unit. We had people with active psychosis, mania, BPD, um, PTSD, and like self harm and things along those lines. And I found that environment really helpful to learn in and how to deal with high acuity symptoms that basically are going inpatient because they need management that they can't get on an outpatient level.
Mhm.
Um, and then that was really intriguing to me. Where I ended up going in the drug and alcohol from there is actually kind of a funny story. I never thought I would want to do drug and alcohol because unfortunately, growing up, I didn't understand the nature or disease of addiction. And I'm not ashamed to admit, I had some biases in my own stereotypes, which made me think, I don't want to touch this with a 10-foot pole.
Mhm.
And I actually got thrown into it. But my internship site closed down for a week because of a lack of nursing staff. So you can't run a residential site without 24-hour nursing staff. So they closed it down for a week. And I got placed into a drug and alcohol program. It was an IOP, so intensive outpatient program, and which means 9 hours a group a week plus one individual session. And I sat in on this group and I remember looking around the room and noticing how motivated all these people were. And I was like, this is not at all what I expected thinking about drug and alcohol or substance use. And I was immediately encapsulated by it. And I was like, these people are so supportive. They are encouraging each other. They're calling each other out on their shit. I'm like,
Mhm.
this is a different kind of realm than where I came from. So I actually ended up applying to that job, got it, ran an IOP for uh, a little over a year at that site before I ended up moving to Harrisburg, where I'm at now. And I loved every moment of it. I ran group for 9 hours a week. It was draining sometimes. Each group is 3 hours at a time, too, just to give an
Oh my
idea of how
gosh.
long
That's a
that
Harry
is.
Potter movie.
Yeah, it's long. So, but it was so nice to work with a population that I didn't think I would ever work with. And I realized there's a lot of misunderstandings for addiction. And now I don't stigmatize it. Instead, I have a lot of mini soapboxes I can get on about drug and alcohol and the justice system and how the state regs work. Um, but that's how I got into that. And I've just kind of continued to work with co-occurring conditions and dual diagnosis, meaning like substance use and a mental health. Um, and I believe that the two of them impact one another. So like PTSD is a primary diagnosis in the substance substance use world. And it's why they created a treatment called Seeking Safety, specifically for women with substance use disorders, because it's like an 83% comorbidity rating. There's other mental health illnesses that are also common: bipolar, schizophrenia, BPD, antisocial, narcissistic as well, schizophrenia, ADHD. So I worked with a lot of it. And I think, honestly, if I hadn't gone in the substance use counseling, I wouldn't have as much compassion for some types of illnesses that I do now, and for where people come from. Like, I've worked with people that have been in and out of jail. Like, I don't stigmatize anymore.
Mm-hmm.
And before I got to that point with the internship, I don't know that I'd be as non-judgmental as I am today. So I'm incredibly grateful for all those experiences.
Yeah, that's really interesting because I'm doing my clinical internship now.
Okay.
But I did one before I started my grad program at an IOP in Alpharetta, Georgia. And what was really interesting about that was, what stuck out to me was what you just said, when like people are calling other people out in the session, and I think therapeutically, like sometimes we're like, how can I like lovingly like bring this person to this realization without, saying like, get your shit together. You know what I mean? And what was really cool was sitting in a lot of those groups that, granted, they weren't 3 hours. So like, honestly, another gold star for you for that.
They're long.
That's so long. But was kind of hearing someone say something, and I'm just going to be blunt, like hearing someone share in a session and you're like, this is complete bullshit what they're saying. And then I clinically don't even have to do anything because somebody else in the group is like saying like, hey, what you're talking about is bullshit. And then I can like facilitate, in a different way. But that was so interesting that you brought that up, because that's something that I remember about those groups was, if I didn't even have to worry about like calling out a lot of things, because sometimes other people in the group would call things out. Also with dual diagnosis, it was interesting because the facility that I was in did a lot. They were dual diagnosis with trauma and substance use disorder. So it was really interesting to see like their interpretation of it was always from that perspective, was always from that lens of kind of like what happened to you, instead of like, why are you doing what you're doing now?
Right. Or what's wrong with you?
Or what's wrong with you? Yeah.
Can't stand that one.
Yeah. And that's like the internal narrative that a lot of people carry into those, into those settings, is there's something wrong with me that I have to fix. And yeah, shifting that narrative, I think, has been really cool, like to see and evolve. I want to ask you about comorbidity. So it's kind of, in substance use treatment, I'm just going to kind of like refer to you. What do you see? You see trauma. Is there anything that's like super common in this group that you see that maybe people don't like have an awareness of or realize? And if not, I mean, I don't know, but I'm just wondering if anything is like popping out to you.
Yeah, I mean, in terms of the dual diagnosis comorbidity, trauma is definitely the front runner. Even when we do intakes in the substance use world, it wasn't uncommon for us to not only ask about trauma, but specific types. So I remember at one point, we would have to update based on DDAP regulations and like ASAM criteria. DDAP regulations is the board for the state of Pennsylvania for regulating drug and alcohol. And the ASAM is basically not universal, America's guidelines for understanding criteria for the substance use disorder as a whole.
Mm-hmm.
When it comes to some of the questions that we would ask, I remember at one point we added a question about being a victim of human trafficking. And it wasn't something that like I thought about initially. And then I took a step back and I thought, that doesn't surprise me, because unfortunately these individuals are so vulnerable, especially if we think about the nature of why somebody would turn to a substance. People say they self-medicate all the time when it comes to substances. And a lot of the answers that I would hear for why did you use substances is because I can't deal with things. It's intolerable. I can't deal with life. It makes me feel better. It gets rid of the discomfort. It gives relief, was normally the answer that I heard. So trauma is definitely the front runner. Bipolar is another common one. And whenever we see people go off medications with bipolar, it's not uncommon when a substance comes in. And there's a lot of back and forth that happens with bipolar, of like using a substance, getting off their meds, kind of a thing, along with the manic episodes and depressive ones. It can just be a whole roller coaster in itself. But ADHD is the other one. So a lot of my clients that I had that had ADHD and substance use disorders, they use stimulants. Guess what treatment we use on a pharmacological level for it? Adderall, which is a stimulant. So it didn't surprise me that they would use methamphetamine, cocaine, because they were trying to self-regulate themselves and figure out how to navigate their brain in a way that it was functioning differently compared to other people. So that's just some of the stuff. BPD, I mean, BPD comes from trauma in its sense. So if we think about trauma, substance use, and then BPD being in the triangle of that, it makes sense that a lot of people that are in substance use counseling or have a substance use disorder also have BPD, because BPD is also impulsive. A substance is one of those things that you can seek impulsively, and once you start, it's not an easy thing to get off. It doesn't matter what it is. And unfortunately, nowadays, weed, it's becoming more of a problem for people. I hate to point it out, but it's something I'm seeing more and more. And it's actually hard to navigate because we don't have a lot of research or guidelines yet for it, because we're trying to adapt with the changes that are going on in a societal level as well, now that it's more accepted like alcohol. So I view it conceptually the same, but the effects on the body are different.
That's interesting. I had a client who was concerned about how much weed they were smoking, and but then was like, they would say in the session, like, yeah, I'm smoking a lot of weed, but I also know that it's not addictive. And I was like, I don't think that is, I was like, I had to kind of therapize it, be like, where is it coming from that you think it's not like addictive? But yeah, definitely like that. Yeah, I've definitely had like clients that have mentioned like, I cannot function without this thing. I, when I don't have it, I have like a reaction, and I'm like, that to me very functionally is like being addicted to a substance. So BPD, I want to shift into that for just a second. So I'm curious about like your definition of borderline personality disorder. Like what does it mean? What does that mean to you?
Yeah, so BPD, when I think about it on a general scale, and normally when I introduce it to people, this is how I'll describe it. It's an it's a mental health illness that comes from emotion dysregulation. In a nutshell, that is normally where it comes from. Along with it, there's a lack of like identity that comes along with it, some impulsivity. A lot of people do have a fear of abandonment as well. However, there's 9 criteria. You only need to meet 5 of the 9 to have BPD. So there's 256 combinations of BPD. I've seen a wide range of them, and it really depends from person to person. But BPD, when I think about a lot of these clients that I've had, most of them do have a degree of an emotion dysregulation. And even Marsha Linehan describes it that way as well. If you don't know about her, she's the founder and basically the big like philanthropist behind DBT. And a lot of her research is very, very wonderful. Her books are wonderful, sometimes a bit dry, but they can be great. And she's the one that
Can I pause
created
you really quick? DBT, could you say just like what DBT is?
Yeah, absolutely. So DBT stands for Dialectical Behavior Therapy, and how it's different from your traditional like CBT, cognitive behavioral therapy. The difference is that there is an element of acceptance built into DBT. So it's 2 major functions: acceptance and change. CBT is a lot of change-based strategies. And unfortunately, what Marsha Linehan realized when creating DBT and like her early stages, where she realized CBT is not working. Why is it not working? It's because the clients that had borderline personality disorder felt like they were being invalidated, misheard, because there was a push for change. And sometimes there's a limit. We can't change everything. And that's where the acceptance piece is so important in dialectical behavior therapy. So mindfulness is built into acceptance, distress tolerance is built into there, and the other two modules are focused on change. So emotion regulation and interpersonal effectiveness. Those four conceptualize the entirety of DBT with the strategies that are taught and the skills that are given to clients. Obviously, there's much more to it that goes than that. But when we introduce this to clients, we describe the four modules and then the importance of finding the balance in both.
Mm-hmm. So I'm curious, like, where I would say trauma, but in your opinion, like borderline personality disorder, what do you see that's like super common between like the backgrounds of a lot of people that meet criteria for this?
You hit the nail on the head. Trauma. So I think there's like a statistic somewhere in Marsha Linehan's book about cognitive behavioral therapy for BPD or something along those lines. It's a red and black textbook. At the beginning, it says, I think the statistic is 75% of the women that have BPD have sexual abuse during childhood. 75%, which is a really high percentage. And it's so disheartening to think about. The rate of trauma is incredibly high. And this is where the emotion dysregulation comes from, in a sense, is a difficulty with being able to tolerate the emotions that can come from trauma and the pain that comes from trauma. And this is why BPD can present as psychological suffering or emotional suffering. And it's so debilitating for them at times. And we describe them as feeling their emotions at the intensity of a 3rd-degree burn. And other people don't experience their emotions to that intensity. So when we think about the amount of pain, like if you get burnt by putting your hand on a stove, it fucking hurts. Imagine feeling your emotions that way, and they come and go so fast. Emotions last 90 seconds, but we can perpetuate them and make them last longer. Imagine the pain that you would experience internally from that. And that's where my compassion for them comes from, is understanding that they're not choosing this. They experience horrific things. I've heard so many stories of various traumas that every time I feel like I might have heard it all, I'm never cease to be amazed that there's somebody that has a story that breaks my heart. They break my heart. And it pains me for them because they don't deserve that. And the hard part is they realize that they don't want to keep living that way. They didn't cause their pain. And it's their responsibility to do something with it. And that's the hardest part. It's their responsibility to learn how to improve their quality of life.
So that's interesting. So basically, like, if I'm kind of like grasping what like you're saying, is kind of like a key thing of borderline is people that feel these extreme, intense emotions very quickly at once. Whereas opposed to maybe someone who's not diagnosed with borderline might say, oh, that pisses me off. But the emotion that's behind someone with borderline is like, times 10. Or, if someone doesn't text me back, right? And I'm like, well, what are they doing? Someone who has borderline might have a reaction of this intense reaction of they hate me, they don't like me anymore. What does this say about me? Kind of like a really extreme reaction, whereas, somebody who doesn't wouldn't have.
Exactly. And that's part of what makes it so difficult for them, is that they experience their emotions at such an intense rate. And it's not uncommon for when they're going through treatment, especially if they're going through DBT, because it's not going to lie, it's challenging. It is incredibly challenging, not only for the clients, but also for the therapist too at times. And when they're going through the therapy, it's not uncommon for them to take multiple days to emotionally recover from one individual session. And they'll experience things where they'll say it takes them 3 to 5 days to recover from something emotionally. I had somebody over the weekend call me for coaching assistance, and I met with them yesterday, and they were still they're drained. They were quite frankly drained and starting to recover from it. They were in a better state. Let's think about it. Saturday, Sunday, Monday, Tuesday, Wednesday. That's 5 days of feeling intense emotional suffering. and having a hard time moving past that. Other people that don't have BPD or don't have experiences like that have a very hard time understanding what it's like to feel your emotions at that intensity. And that's part of why they have a lot of interpersonal conflicts, because other people don't have the understanding and compassion to be able to get them the way that they want to be understood.
Mm. So I'm curious, what is it like for you as someone who's working with someone with borderline personality disorder who is having this kind of emotional reaction where they're needing a lot of time to rest and relax? So I'm going to bring up something, is that I know a lot of times in trauma treatment, like people may, like doing EMDR or anything like that, people may like stop showing up to sessions, or people may start calling out. And sometimes it's unconscious, sometimes they're like, no, I really feel bad, but it's like, you didn't feel bad for the past 10 sessions, but you feel bad now. I'm wondering, like, do you see that a lot when you're doing this with people with BPD, where they're like, oh, things are coming up that may not even feel like connected to what's happening, but it's like something maybe somatic even.
Yeah, it can definitely happen. And that's one of the reasons why dialectical behavior therapy is great for individuals with BPD, because built into it, when people are following it the way that it is prescribed for the treatment, coaching call is something that's a resource to them. And if you don't know what coaching call is, it's basically a skills support resource where clients can get troubleshooting, they can get feedback, and they can prevent themselves from acting on urges, whether they're self-harm or other things. The other function of the therapist as well is to have inter-session contact, meaning if I know that we had a heavy session, or I'm noticing like a change in somebody's presentation, or they call it to coaching and say maybe they don't show up to group, it is my responsibility to then reach out to them on that inter-session contact level and be like, hey, I know that this is going on. Can we talk about this briefly? Like, to re-engage commitment. So as a DBT therapist, you're trying to consistently utilize commitment strategies to re-engage the client, especially when they go through a difficult session or they're having things outside of the therapy room that make it challenging for them. We recognize there's going to be a lot of challenges. So coaching is a support, inter-session contact is a support, and our entire functioning is to be able to validate the acceptance piece and probe for change. So it's a balancing act of the two of them. And that might be something that I do, is like, if I know that a client seemed kind of off at the end of the session, I might reach out to them the next day. This is not always an easy decision to make, though. There will be times where I've had clients slam my doors and storm off, and they say, fuck it, I'm going to go kill myself. They storm off, they leave my office, and I don't hear from them. I have to sit with the discomfort and make the decision call of whether to reach out to them or not. In those times, I haven't. And I was actually really grateful, because I'm thinking about this one time that happened with the client. I had the coaching call phone. That client had called me, and I said, I'm really glad that you called, and I'm looking forward to seeing you tomorrow. That's me trying to re-engage the commitment, show like, I care for you. I know this is difficult, and I encourage you to keep making progress for yourself by coming into group tomorrow.
Well, that's really interesting too, because I feel like a lot of times I have one client with BPD, diagnosed. And it's interesting because a lot of the things we do, not specifically together, but just like I feel like in therapy in general, is to encourage this secure connection of like, hey, you can be mad at me. Like, you can be upset. We can have awkward moments. We can be like, annoyed with each other, but we still are like maintain this like security of our roles in our relationship. Is that kind of like really, that sounds like that's really integral into that, into saying, hey, I know you were mad, and I know maybe I did whatever, but like, I'm still like going to be a secure person for you to be able to talk to.
Yes, exactly. We want to try to embody that, because a lot of individuals that have BPD don't have that example in their life. Probably very few of them, if at all, do. Most of them have very insecure relationships, disorganized growing up. And we recognize that we want to try to model what it's like to have a secure relationship. And what that means is I'm going to give you space to figure things out because I'm going to treat you like a capable human. I'm going to assume you're competent. And if you need something, I will be there to help you, but I need you to ask. So we'll have, like, I've had clients previously that'll just like walk out of the room and I'll see them outside the door waiting for me to look at them and give them attention. And here's the thing, I'm not going to go outside that door until you make a signal for me to come out and help you. When you do, guess what? Then I'll come out because I want to be that secure attachment and model what that can look like. And that takes me being cognizant as well of knowing how I can model that behavior. It can get exhausting sometimes, though, because we have to keep our own shit in check. And when we have a distress intolerance and my client slamming the door, walking out of my room, I had to tolerate my distress of wanting to reach out to that client because I cared and I didn't want them to hurt themselves. And I knew there were risks. And I had to sit and wait. And that's a really hard thing to do. And guess what? They reached out. So I treated them like a capable human. And if I reached out to them before, I could have accidentally invalidated them or inadvertently reinforced that you're not capable by me trying to hold your hand. And I don't want to do that.
So it's interesting. You tapped into something that I think is really common just from like my understanding of BPD is that there is this element of people with BPD will kind of like test you to see if you'll come for them, to see, the kind of people that are like, don't follow me, but really want you to follow them. And kind of what you're saying in that moment is that you had to not buy in, that like the purpose, like clinically, that with this disorder and knowing that that's what happens, you had to kind of be like, not buy into that thing. Oh my gosh, how difficult is that because see, it's interesting. So I've only worked with it with one client and I'm like a little baby therapist, but this client I have has an awareness that they do it.
Okay.
And so we're able to kind of really like, I guess cognitively, like think about like what that is and another way to express like their needs. And so that's interesting that's coming up, that we have to kind of invite some kind of like accountability and be like, no, if you want me to like react in the if you want love and support, you have to like ask me for it. That's essentially what you're saying, right?
Yes, that is exactly what I'm saying. So, this behavior is so common to the point where there's a term for it. It's called active passivity. Okay. So what this means is that individuals will not ask for what they want. Instead, they will try to make these little nuances or gestures of trying to get somebody to pay attention to them and ask them what they need, because they don't feel safe in asking for what they want for themselves, because past experiences taught them, if I ask for my needs, I'm going to get hurt in some way, shape, or form. That's where that comes from. So if we can have compassion for understanding where it comes from and recognize that's not adaptive or effective for meeting your needs in the future, it's also not treating you like a capable human, then it is my responsibility to go, okay, I'm not going to ask you what you need, because here's like a common example that we might see in the group room: hood up over the head down on the desk after something happens, where they'll come in that way. That to us is an example of what active passivity might look like. At the front of the room, guess what I might be thinking? I want to see what's wrong. I have that thought. That thought is there because I notice the behavior and I go, what's up? Like, I want to know what's going on so I can help, because that's my nature. I genuinely give a shit. But here's what I'm not going to do. I'm not going to go ahead and notice that behavior and ask them what's going on, because they're not communicating with me. So I have to tolerate my own distress and sit there and wait for them to come up and go, which I've seen happen a lot. And I'll be like, okay, we'll go out with you in the hallway. And I'll be like, what's going on? What do you need? But you need to ask me. I'm not going to just go up to you. Same thing if you slam the door and walk out, not going to follow you. That's on you. If you come back, then I'll talk to you. But I'm not going to chase you out of the building.
Yeah, that's interesting. So I'm curious about, like, just to complicate this a little bit, because it sounds like working with it in general, like, is like many things, it's really challenging and challenging on you individually. I'm wondering, when you throw a substance use disorder into the mix, how what does that look like for like a clinician? What is that?
It's difficult. So it depends on the severity of the substance use disorder. So if somebody is actively using, DBT is not going to work. And it's actually one of the elimination criteria for it of you have to be willing to appear or be sober when coming into treatment, or at least be willing to like make steps and make progress. Because if you're using heavily for a substance, we can't do treatment that is going to involve figuring out what's going on, pulling things apart, because being able to do that means assuming that you have enough tolerance to be able to withstand what we are going to challenge behaviorally in you. If somebody is using a substance, their behavior is communicating to us, you're not ready for this, and that's okay. So as somebody that does DBT, substance use counseling, and a mix of things, if they're presenting to me and their primary concern is the substance use, I'm going to address that first. Because their level of care needs are higher, their severity and their risks are higher, not only for their mental health, but also physical health, depending on what they're using. So I will go, we need to address the substance use, get that under control, and then come back to the BPD. When it comes to working with them in tandem, when the substance use is manageable, then it's figuring out if you are using, but it's not inpatient level of care or partial level of care and it's outpatient level, what is it that prompts you to do this thing? What skills are you not using? Where can we give you skills? What are the consequences, vulnerabilities, all these factors I'm thinking of in my head. And if you've ever seen a behavior chain analysis in DBT, those are the elements of it. So I'll think about that. And then I'll also be thinking about what are some of the like other things from the BPD that contribute to the substance use. Because I recognize that there are behavioral challenges in BPD that can perpetuate the substance use, and then that can perpetuate BPD. So it's like a cycle.
You've got this like feedback loop happening.
Yeah, you got a feedback loop, and you have to know what the severity of each is at and figure out how to balance these things and find the middle ground of it, which is a lot of give and take. It's a lot of pulling things apart with the active willingness or willfulness of the client.
Mm-hmm. It's interesting because you mentioned, we have to manage the substance use before we can go in a little deeper. I don't know why this is coming up for me, but I remember working in substance use for a little bit. Kind of one of the things that was a big focus was what's going to kill you the quickest. So basically, we would have clients that, because I've noticed a lot of people with substance use disorder, like when they come in and they decide they want to get sober, they're like, okay, I'm going to quit smoking. I'm going to start going to the gym 5 days a week. I'm going to have this perfect diet. And it's like, okay, girl, you need to bring it way down.
That's right. It's not going to work.
Yeah. And so that's what's like kind of coming up for me when you're mentioning that, is thinking about in that setting, people being like so ready to jump into things, and then to just happen to be like, hey, we need to like take it like one kind of like step at a time. Do you ever have any reaction, and this might be super specific, but do you ever have any reaction of someone coming into treatment who maybe has had a previous diagnosis of BPD, who is like, hey, I want to work on all of this like right now?
I mean, it's not uncommon for me to get, with the setting I'm in right now, it's not uncommon for me to get people reaching out, especially given just the nature of my Psych Today profile, and be like, I have BPD, or I think I have BPD. I want to work through this thing. That's a lot of what I've had recently. And with that, it's my responsibility to help them work through it and figure it out together, but also to accurately assess the risks. So one of the ways that I'll do that to get them to open the door and tell me what's going on is I'll say, look, I don't want to send you inpatient right off the bat. That's not my goal. And if you have BPD, it's iatrogenic, meaning it's going to cause more harm than good. Not my goal at all. So I'll say, I want you to be able to talk about these things in here because I want us to be able to explore this non-judgmentally together, like we're detectives trying to figure out what's causing suicidal ideations or self-harm. Sometimes when clients are acting on behaviors, and if I'm seeing an escalation, we have to take it at face value. If you're telling me that you are going to suffocate yourself with a bag, or you're going to drink gasoline, bleach, or whatever it is, swallow things, I have to take it at face value. My treatment at an outpatient level can only go so far, and that's where I might go, you need to go inpatient at this point. I've had to have that conversation with a couple people that were actively acting on what we would call a life-threatening behavior, whether it's suicidal ideation, self-harm, something else like really severe that falls into that category, but it's normally those two. I'll take it at face value. I'll be willing to explore things and help give skills. But if there's a lack of commitment to refrain from acting on those urges, me being able to help you on an outpatient level, it's not going to help. And that's where I go, you're going to need to go inpatient. And when you come back, I'll be willing to help you. Sometimes here's what we do though. If somebody tends to go inpatient, where we understand that this person is someone that seeks out some form of support from inpatient settings, we might reach out to the setting and go, make it more difficult for them, meaning make them not want to come back, create a consequence, because their behavior is not sustaining to a life worth living. We don't want people to be living their lives in and out of hospitals. We want them to live their life. So if they are getting reinforcement from an inpatient setting, it's not uncommon for DBT providers to try to reach out to the setting within range, within what reasons that we can, obviously, and encourage them to make challenges so it discourages the behavior to continue. We want to put barriers from creating life-threatening behaviors. If that makes sense.
I think so. I think I'm picking up what you're putting down. I want to ask, what does two more things just to kind of like wrap. What does it look like for someone internally to have BPD? So I'm curious about, like we mentioned kind of like the intensity of emotions. If someone is thinking that they may kind of like that this diagnosis might be what they have, or they feel like they have certain traits or anything, what is kind of like, is there something that is kind of like a key kind of like indicator of maybe we should be curious about what's going on?
Internally to them, as it's described and from them and from what I've seen like in written stuff, it's intense psychological suffering. That's what it comes down to. And when we say suffering, it means pain plus non-acceptance. So they're not accepting of whatever is going on. And this is where it's really hard sometimes, because a lot of these people do have trauma, and we go, you did not cause this, yet it is your responsibility to learn how to manage it. And I say that, and some people have very strong reactions to me. And I say, I don't mean this to be invalidating. I mean this for you to be able to feel empowered to take agency and control over your life. And a lot of them internally feel like they don't have control over their life in some way, shape, and form, because they had a form of traumatic invalidation, a lot of them. And it's what we call it, where they were invalidated over and over and over again. They feel like they don't have control of their lives, and they're desperately trying to get some. The problem is they're doing it in ways that are really harmful to themselves, to relationships. And it feels like life isn't worth living. Life sucks. And I just want to die. And I hear that all the time. I want to drive off a bridge. I just want to kill myself. I hear it over and over and over again from these people, because their inside brain, their emotions, their body is in so much pain that they can't take it anymore. Imagine a cancer patient not having their treatment, not having pain meds. That's kind of what it feels like to have BPD and have it be from psychological roots. So that's what it feels like to them.
Why do you think that so many, because I've spoken to like clinicians that say, I do not work with people that have borderline personality disorder. What are your, is there any thoughts or feelings there? Because some people, if they hear it in an intake, they'll immediately refer out.
Yep. So it's not uncommon, unfortunately. And that's why with my Psychology Today profile, like I indicate that I specialize in it. I have a passion for it, because quite frankly, I do. And that's why I get a lot of clients reaching out, because they've had a lot of therapists that have said, I can't keep working with you, or they realize like this isn't going to work with other people, or a therapist will turn them down. I think, unfortunately, there are a lot of reasons as to why that happens. Part of it is a lack of understanding of how BPD makes clients feel. And I think a lot of it too is when a clinician experiences working with BPD, it takes a toll on us. It really does. And we will tell clients when we're getting burnt out with them. That's part of DBT. That's the glory of it. If somebody's burning me out, I'm going to tell them. But here's the thing, I'm going to describe why. I'm going to tell them what in your behavior is making me feel burnt out. Because I don't want you to burn other people out. But some clinicians that don't have that training and expertise and a lack of knowledge is what it comes down to. I don't think it's intentional at all. I think they experience working with BPD, realize it's tough, don't have a full comprehension of what it's like to treat them, and don't have a support of a modality that works, and they get burnt out from it. So I get why they don't want to. It takes a lot of training and willingness. And quite honestly, working with this population can be really draining sometimes. It's why my entire caseload isn't BPD. It was at one point, and that was a lot for me. I genuinely enjoyed the work. And then I realized I need more of a balance of other clients that help balance out the psychological suffering that I'm taking on from hearing their suffering, because I empathize with them. I don't want them to have that. So I feel the pain they're going through. And that's exhausting for clinicians. And some people just don't know how to work with it because they don't have the training, education, or the desire to work with a population that can take that much of a toll on you.
So I want to ask a rounding up question just to kind of like finish things off. Well, I have two. I lied.
Okay.
So what does recovery look like and growth for BPD clients? Like, someone comes in and they're really kind of suffering, and this is, something they're really going through, and then they work with you. Like, what does it look like to see like those success stories, or to see the people that have really made growth and progress? Like, how does that, can you tell me about that?
So obviously it's going to vary from person to person, just like anything. But here's what I love about DBT as a treatment for borderline. It fucking works. It works. When you follow it the way that it's done, the skills training, the individual counseling with a diary card, coaching call, consultation to the team and the clinicians, it works. So when I worked in a comprehensive DBT treatment center before where I'm currently at, I'm now in a private practice. I have a bit more range. I worked in a comprehensive treatment center that was also an IOP. So another 9 hours a group a week. That was a lot. But here's what I saw. They were there for 13 weeks of IOP, 2 weeks of pre-treatment. So I'd work with them on average for 15 weeks. A lot of them made significant progress. I'd see GAD scores from off the charts go down to a 4.
And
And
that's just, if you don't, that's general anxiety, right? Yeah.
the GAD scores is the general anxiety. You can see the same thing for the PHQ, which is the depression rating. I would see them go down significantly. So here's what I love about BPD and why I don't view it as untreatable as some clinicians do. It's highly treatable. If you know what the treatment is and how to utilize it, highly treatable. And it's one of the diagnoses that I feel like can fully go into remission, because BPD is a diagnosis that's based in personality and behavioral ineffectiveness. If you are modifying the behaviors, you are modifying the personality, and you're modifying somebody's quality of life. So I actually had a friend that had BPD, and I used to work with her at the comprehensive unit. She used her story as an example of, I've been in remission for years. I have symptoms now and then, but I don't meet criteria anymore. So I think it's more highly treatable than people realize, as long as you're going to a therapist that knows what they're doing. Because when you don't have a DBT therapist, then it's going to be, you can make progress, but I don't know what the efficacy is compared to something that is like literally called the gold standard model of treatment for it. But in a nutshell, highly treatable.
Yeah. I love to hear that. Um, I want to, well, first off, I want to thank you so much for like coming on here and for doing this. Also, I wanted to just ask you one last question. Like, I'm wondering if there's something about like being a therapist, if there's something about working with people that you like really would like to share or that you feel really strongly about like with your work. Like, I'm wondering if there's anything that's coming up for you or anything that you like wanted to share in that regard.
Yeah, I think one of the big things that I've learned is if you're sharing skills with a client, be willing to do the same work yourself. It's hard. And I think it's so helpful if you can practice the same skills you teach and preach to these individuals, no matter what population you're working with. And the other thing, take a fucking step back. Seriously, like if you are noticing
As the
that,
team.
yeah, take a fucking step back, because if somebody's talking about something and they're discussing how important or how harmful this thing is for them, take a step back from your own point of view and try to understand it from theirs. There's gonna be things that you cannot fully understand. And if you take a step back and try to wholeheartedly understand them from their point of view and drop your stigmas, you'll get to understand people on such a different level, to the point where you'll help them make progress in ways that they didn't know that they could, because you're willing to be there for them. And that's what it all comes down to. Like, I worked with people that have committed an array of crimes, a whole fucking array. I don't stigmatize anymore when I see people that are incarcerated. Instead, I want to know, what is it that contributed to you doing this? And is it something that you want to change? Because not everybody does. That's okay. I just want to know why. So drop back on your stigmas and be there for people in a way that they might not have ever had before.
It's really beautiful.
Thanks.
I feel like I could get that like tattooed somewhere.
Right.
Well, thank you so much for coming on. Thank you for agreeing to do this. I really enjoyed chatting with you. And I hope to like maybe chat with you again at some point. But yeah, thank you so much, Karley, for coming on.
Yeah. Thank you for having me, Dustin. This was really great. I genuinely enjoyed talking with you and sharing a little bit about BPD. Hopefully people can understand them a little bit more. That's my hope.
I hope so. I think they will. I think they will. Well, thank you so much.
Yeah. Thank you.